Okay, let me know if you guys can see the presentation screen.
Yep.
Cool. Okay. So for this presentation, I kind of have it as like a more of a grand rounds type of presentation. And what I wanted most of you guys to get out of this, and something that I really wanted to emphasize in this presentation, is the application of scoring systems. I think kind of that's something that we take for granted going from our second year in step one into more of our clinical practice. I think the emphasis on scoring systems and how they are applicable to patient management is very limited. But you'll hopefully see at the end of this presentation the benefits of these scoring systems and how they can augment our treatment plan for our patients. So this is good for especially those of you guys that are doing your surgery rotation right now. Oh, I see. What's this? Just so FYI, your camera. Oh, sorry. Ha! There. Sorry, y'all. So my presentation's on perioperative management of deep venous thrombosis. And here we go. There we go. Okay. So the case that I'm presenting, she's a 56-year-old female. And she presented after 3 days of a post-op IND for an abdomen and right breast wound that she had as a result of a complicated breast reconstruction. And she's presenting to the emergency department with complaints of 2 days of right calf pain and swelling. So I'll get into her past medical history. Her past medical history is a breast cancer, and I'll talk, that's the primary focus related to the surgeries that she underwent before her presentation to the emergency department. She also has a previous history of DVT in the left lower extremity, fibromyalgia, lupus, and rheumatoid arthritis. For her surgical history, currently at presentation in the emergency department, she was 19 days post-op for a bilateral breast mastectomy, and then reconstruction via a DIEP flap procedure, which is a plastics procedure I'll go into in the next couple slides. She also is 3 days post-op from abdominal and right breast IND after that breast reconstruction that she had undergone. And she also has had a history of cholecystectomy and carpal tunnel release. So she had undergone 19 days before presentation, a breast reconstruction related to the double mastectomy for her breast cancer. This breast reconstruction is called a deep inferior epigastric perforator flap. And so essentially what they do after the double mastectomy is this can either occur immediately after the double mastectomy, or it can occur multiple months later. And in that case, if they perform this procedure after the mastectomies multiple months later, what they'll usually do are put spacers underneath in the breast tissue to prepare for this DIEP flap. And so in the DIEP flap, what they do is they take the skin and the subcutaneous fat from your deep inferior epigastric area of the stomach. And then they're going to go ahead and translate that over and connect the deep inferior epigastric vessels to the mammary arteries and vessels, vein, pardon, in the chest. So this is great for patients that have both, breast cancer and they've undergone mastectomy. It's good because now they're transitioning their own tissue, and rather than having other prosthetics that are added to that to their breast, it's their own skin and their own subcutaneous tissues and fat. However, these procedures take a long amount of time. So average procedure time for just the DIEP flap procedure in and of itself is 6 to 8 hours. So some of these patients that are going through the double mastectomy and the DIEP flap procedure one after the other, these patients can be under general anesthesia for up to 11 hours. This patient, she had, for her procedure, I think it was about 9.5 hours in total for her to be under general anesthesia. So a pretty significant procedure. These are her medications preoperatively, not too important. The one thing I just wanted to kind of highlight is that her medications don't include any type of blood thinners. And then her allergies, she's allergic to penicillin, and she also has a 20-pack smoking history, 20-pack year smoking history. So on physical exam in the emergency department, Her vital signs were pretty much stable. Her general appearance, she's a middle-aged, obese female. She wasn't in any acute distress. She just was coming in with that moderate swelling and redness and tenderness to the right upper calf. There was no thigh tenderness or pitting edema bilaterally, and there were no sources of injury or signs of injury. And her range of motion was fully intact, as well as strength and sensory. Her chest and abdomen were significant for the 2 large incisions of her breasts, as well as a long incision over the lower abdomen from her previous surgeries. And she also had some drainage and purulence of a left incision breast. However, her right breast and the abdomen there was no tenderness, no discharge, no bleeding or pus or redness. And she did still have 2 JP drains with blood and serosanguinous fluid as a result of her original deep flap procedure. So differential diagnoses related to her right calf. Primary was a deep vein thrombosis, also soft tissue injury or hematoma. You could have compartment syndrome, which presents very similarly to DVT with the 6 Ps, the pain, pallor, paresthesias, etc. Also cellulitis, muscle strain or tear. And then this is not a completely inclusive differential diagnosis list, but those are some of the top. So this kind of transitions over into talking about, okay, if our top primary differential diagnosis is DVT, what can we use to kind of support that as a top differential? And so now we're going to go into labs and imaging. So for her, significant labs related to her DVT would be coagulation studies. So her prothrombin time, her INR, and her PTT, which were all elevated. And it's not completely understood why all of her PTT, her INR, and APTT were elevated, outside of the fact that under her second procedure that she is presenting 3 days post-op from the IND, they only gave her 1 bolus of heparin. And then what also was significant was that her white blood cell count was 14.5, so elevated, and most likely related to that wound debridement that she had just undergone, as well as some infections still related to her left breast. So now applying some of that scoring that I was talking about. So Wells scoring system, this is typically used for DVT and pulmonary embolisms. And it's used to predict the probability of a DVT. So we typically see this in the emergency department. They'll apply the scoring system to kind of rule out whether or not there's a likelihood of a patient presenting with DVT. And significant for her was a +1 for cancer that's been recently treated within the last 6 months. That she also had undergone a major surgery, not only the deep flap, but also the IND procedure, which lasted for a couple hours. So 2 procedures that lasted, that were significant in time length, and that lasted within the last 4 weeks. She also had that tenderness of a deep vein, a swollen leg, and also a previous history or diagnosis of DVT of the left lower extremity. So using the scoring system, interpretation is that she was at high risk for DVT, and that DVT in this case is likely, and therefore further testing or imaging should be indicated. And so by further testing or imaging, that's related to the Doppler ultrasound. And so on the Doppler ultrasound, it was conclusive that she did in fact have a right posterior tibial and peritoneal vein occlusive thrombosis, and thus she did have a DVT. I'll pause here and talk about a little bit. So for the Wells scoring criteria, if there was a low likelihood of DVT, alternatively, rather than doing a venous Doppler ultrasound, you would go ahead and do a D-dimer test to see if the D-dimers were elevated, indicating that there was some type of thrombotic event or activation of the clotting cascade. So assessment for her, 56-year-old female with that recent breast reconstruction within the past 20 days, and she's admitted for the post-op wound infection related to the left breast, and she also now has acute DVT of the right popliteal vein. So further management, there are 2 things that she's now presenting with. First of all, she has that DVT that she presented to the emergency department with. And then second of all, she still has a post-op wound infection, specifically the left breast, that needs to be handled and taken care of. So the rest of this presentation kind of talks about, okay, not only did she just undergo these two extensive procedures resulting in a DVT, but she also still has a third procedure that she needs to undergo. And how are we going to continue to manage this patient knowing that she has a DVT, which is a medical emergency, and we want to avoid the risks of that potentially turning into, for example, pulmonary embolism. So research question, how can we reduce the risk of perioperative DVT in breast surgery patients? So I went ahead and used this study that was done by Brigham Women's Hospital in Boston. And so the basis for them doing this study was that they had a significant amount of their patient population coming back in postoperatively with some type of venous thromboembolism, whether that was a deep vein thrombosis or a pulmonary embolism. They had both of those increasing their morbidity and mortality rates of their post-op patients. So they wanted to go ahead and kind of look back and see what criteria are we doing, or what scoring systems are we using to categorize our patient populations, and what are we doing prophylactically so that we can improve our results and outcomes and limit the amount of VTEs that are coming in postoperatively. So this study uses this scoring system called the Caprini risk assessment. This differs from the Wells scoring system in the fact that Wells scoring system talks about specifically the likelihood of your patient presenting with a DVT or pulmonary embolism. But the Caprini risk assessment does is it categorizes your patient into a risk, whether it's low risk, medium risk, or high risk. And then you can go ahead and tailor a prophylactic treatment based off of what risk categories they fall into. So this risk assessment, there's a whole bunch of lists of all of these different risk factors. I'm not going to go through all of them, but some of them that are important that are kind of related to my patient was age, whether or not she went over a large surgery, a major open surgery. They have it classified as greater than 45 minutes, whether they had a malignancy, other things such as sepsis over less than a month ago. Also some other histories of venous thromboembolisms, or some other histories of like lupus anticoagulants and other inflammatory conditions. So this is the actual assessment. And then after you go through and you assess your patient and you grab a score, you can go ahead and now apply this to what types of medical management you're going to be performing. So if a patient is at very low risk, they say there's no specific pharmacological or mechanical, meaning things like compression stockings or SCDs, so the calf compression, manacle compression. So that's very low risk. Low risk, that's going to be your traditional patients. Usually those are going to be your mechanical prophylaxis. So whether those are the compression stockings like I talked about or the SCDs. Patients that have moderate risk, they suggest that you're going to have to undergo some form of pharmacological prophylaxis like low molecular weight heparin or mechanical prophylaxis. And then those patients that have high risk, those are the ones where you're going to want to include both a pharmacological and a mechanical prophylaxis, as well as they suggest the patients undergoing a pharmacological prophylaxis for an extended period of time post-operatively. So for the summary related to this study, they said that the reported incidence of VTE following breast surgery, it can range from 0.16 to 0.4%. So it seems like a low percentage. But still, we know VTE can result in death via pulmonary embolism, et cetera. So they use the Caprini scoring model to establish the risk and then guide their clinicians into appropriate prophylaxis for their patients. They had a total of 522 patients, with 89% of them having what they consider a high risk Caprini score of greater than 5. And resulting at the end of this, after the application of the Caprini score and prophylaxis, they only had one incidence of DVT within 30 days of their surgery. So although they didn't break the reported incidence to have it less than 0.16, they resulted in a VTE rate of 0.2%, which is still on the lower side of the traditional 0.4%. So applying the Caprini score assessment to our patient, she got a +1 for age since she's 56, a +2 for having surgery under general anesthesia. That was a long comprehensive surgery, +1 for a major surgery. I don't know why there's two different ones, but that was just what the scoring system said. +3 for a history of DVT in the left lower extremity. She also was obese, so +1 for that as a risk factor, +2 for the previous malignancy. And she also has +3 for lupus. So based off of this, she has a 13 points of the Caprini assessment, and that puts her in the high risk category because she's greater than or equal to 5. And applying this to what type of prophylaxis she should have been put under, she would have not only the mechanical, but also the pharmacological prophylaxis. So she should have had the pneumatic compression devices, as well as a low dose of heparin or low molecular weight heparin, and a follow-up of 30 days duration for chemo prophylaxis, such as something like rivaroxaban or enoxaparin. So the initial plan that the surgery team came up with was to start heparin after they identified that she did have that DVT, as well as start IV antibiotics since she did have the increased white blood cell count and still had some wound infection. And they wanted to place an IVC filter prior to her going in to the operating room for that debridement of the left breast. And then the rest of traditional, putting her on NPO with IV fluids, as well as trending the lactic acid and white blood cells for her infection, and monitor the culture of the left breast wound. So you notice in here in the initial plan, it just says start heparin, and then also put the IVC filter. So this is great in the sense of inhibiting that DVT from becoming a full wound pulmonary embolism, but this doesn't really change the fact that she has a DVT, and it also isn't going to do a whole lot for her post-operatively in long-term management. I'll talk a little bit about what an IVC filter is. So it's basically minimally invasive. What they can do is they can put this filter in, and then it kind of just situates itself in the inferior vena cava, and it'll inhibit any type of peripheral venous thromboses to travel through the IVC into the lungs. So that was the plan. What they actually ended up doing is the patient elected not to have the IVC filter placed. So she did undergo the left breast wound debridement, and they did treat her perioperatively with 500 units of heparin subcutaneously, followed also by 500 units every 8 hours post-operatively until discharge. She did have the SCD devices placed, and she also was discharged home with a 30-day supply of rivaroxaban. So that's that 30-day chemo prophylaxis, as well as a consult for follow-up with vascular service 2 months afterwards, since she did have the DVT history and the current DVT. They wanted to continue surveillance for her post-operatively. So although their initial plan was to just place the IVC filter with no prolonged prophylaxis, they actually did end up using the suggested Caprini scoring system prophylaxis, where she was high risk. She was given the low molecular weight heparin, as well as mechanical prophylaxis, and then also continued to have the pharmacological prophylaxis post-operatively for 30 days. So that kind of is the end